Good afternoon, sir.
Good afternoon.
Sir, Dr. Nasreena is here.
Yeah. Hi, Dr. Nasrina.
Hi,
Yes, sir.
Congratulations that
thank you.
you have passed.
Yeah, I cleared this time.
So, Dr. Nasrina, where you are working?
Actually, I just moved to UK 3 months back. So currently, I am yet to register GMC. So
Okay.
yeah, I'm planning to join in UK. I was working before that in Aster MIMS, Kerala. I'm from Kerala.
Kerala, sir. Okay, okay. Have you got the interview date in Royal College or you are preparing for that?
No, I didn't, because if I have to attend the interview, I can attend the interview before GMC registration. I am still applying for it.
And Nasrin, today's meeting because of two things. One thing is to give you a congratulations,
Thank
and
you.
second thing we are planning to end of January to do a one webinar where we will give you the honor certificate from the Farz Academy that you have passed the exam,
Okay.
and for in bigger way congratulations with all teachers who teach you in your
Yeah.
journey. They will be there. The Farz Academy mentor will be there, and the second
Okay.
thing, our student will be there who will appear for the exam in the next year. So
Okay.
you give them a little bit insight of the preparation, how you
Okay.
have made your journey successful.
Okay.
So that thing you will do, you give some motivational speech to them. And
Okay.
also we want you people, those who pass the exam, to take
Mm.
them in a board as a examiner for, or as an expert for the mock examination. Okay. So
Okay.
we are going to conduct mega mock test for the part two,
Mm.
and where we want you who phrase pass, they have good knowledge, they know the exam pattern, so they will
Okay.
help them a lot. So
Okay.
we will take a few minutes more. Just we want
Okay.
to discuss what are the cases you got in the CCS, and what are the OSCE you might get, you got in the your table, like your CBS. So
Okay.
Fatma, you please do note down. Okay.
Sure, sir.
Yeah. So Nasrin, तुम्हारा लॉन्ग केस में क्या था?
Long cases, actually, this time they gave two long case and two short cases, like it was
Okay.
before. And long cases, one was about a one I think around 60-year-old male, um, and they have given obese male. He had some history of cardiac disease, cardiac heart disease, and I can't remember now. That time I
Yeah.
remember. So he actually underwent a surgery for his abdominal aortic aneurysm, which was bleeding, and he had a history of aneurysm for which a graft was placed, and that from there again he came with some bleeding or abdominal pain. So they took him for a surgery to for repair of those that graft, something like that related. And he was brought back to our ICU on ventilator, and he was on hemodynamically unstable with vasopressors. And then after that, in the ICU itself, patient had gone into atrial fibrillation. He also had decreased urine output, and these were the things. And ABG showed some metabolic acidosis with high lactate, and this was ABG picture. ABG also they gave. And the investigations mainly they showed the hemoglobin was on the lower side. If I don't I don't know if APTT INR was high, but CRP they gave normal, so that there is no features. They want us to exclude septic shock for this, no infection features, and the counts were also normal. Um, After this they asked like what are the issues, so we had to tell all this from airway on breathing circulation approach. I told like hemodynamically unstable on vasopressors, and also atrial fibrillation with fast ventricular rate. This was the causes for and the cause for shock was mainly hemorrhagic shock and this atrial fibrillation with fast ventricular rate. Then the thing was like this the case. Mainly it was like this, post-op patient with atrial fibrillation, what will you do? So they wanted mainly for the atrial fibrillation I should have given, I told them synchronized cardioversion as well as amiodarone. They wanted the answer to be amiodarone, because in the next vignette they showed patient was given amiodarone, and the vasopressors were coming down. I don't know if they stressed on the blood products, but I told we'll give blood products, correct the INR, we'll correct the hemoglobin, we'll keep it above 7 and all that. Then they asked, then also patient had oliguria with lab showing increase in the creatine. So there was AKI, hyperkalemia, oliguria. So they wanted what I will do next, CRRT in this scenario with hemodynamic instability. Then after, then in the CRRT section, they asked me, there was a alarm, and the nurse alerted that this alarm, where was the alarm? Alarm was because of filter clotting. That part I missed, because the patient was not on heparin because he was having bleeding issues, INR was high, heparin cannot be given. I believe that patient also had some liver injury, so citrate was also not given, so none of the anticoagulation was given, so the filter clotted. So they asked, I think, what will you do next? I think maybe prostacyclin was written in the next vignette, maybe they wanted that answer or to be told. I don't know if prostacyclin is used, that is one of the anticoagulant. Then they asked if okay, slowly patient started making urine, he's producing urine, so how you will wean from CRRT? This was the question. This time they focused on weaning from CRRT rather than the settings of it. But somewhere, I don't know if we have to mention 25 to 30 ml per kg per hour. Then they asked, how will you wean this patient from CRRT? So he was making enough of urine. His ABG, second ABG showed acidosis was better. Acidosis was better, creatine was improving, urine output was also there. So, and his the vasopressors were also coming down. So I told, yeah, it is time to wean off to CRRT. I think their next vignette also showed that CRRT was weaned. So it was basically of weaning from CRRT. How do you wean? That was the question. So they gave the scenario, and then we have to tell accordingly. The next question, the next vignette they asked, they showed the chest x-ray. Chest x-ray had some infiltrate, and so they asked me, will you intubate this patient? So patient's FiO2 was around 50. PEEP was also around 10, 12 something. And there was X-ray was showing some effusion, some infection features. So, and patient was in some tachypnea was there. So I told we will not extubate, and we have to tell that time what are the weaning issues, like that airway, breathing, circulation, delirium, everything we have to tell. I think they expected. So all weaning, what all we have to look to wean a patient if there is weaning difficulty. This was the vignette question. Then next was patient actually had, I think, developed ventilator associated pneumonia or something, because they showed a lab report showing WBC was high, patient was having fever. So probably we have to look for all, we have to tell again, we have to send culture. We have to do the septic screening by sending the repeat cultures, the sputum, everything. Then the next vignette was correct only, because in that they said patient cultures were sent, and he was having some infection, and now he was started on meropenem. They actually started on meropenem, but I told the answer as according to the hospital antibiogram local policy and all. So their next vignette had meropenem and all. Then they said, how will you de-escalate the antibiotic? So we have to tell that procalcitonin, looking at the clinically as well as by looking at the lab parameters. Then they close the vignette. That was the end of it.
Good. It was a very good session.
Yeah, that's how that it was basically a post-op case. They covered CRT, how to wean from CRT. He developed weaning issues. Then it was mainly VAP. Then how do you manage sepsis and de-escalation of antibiotic? Second
Then
case.
second case, yes, second case.
Second case was about a long case. It was very clear, straightforward case. It was there in our Farz Academy also. The case was pneumonia, community acquired pneumonia. The patient, I can't remember the features. He developed shortness of breath. Patient came. But the lab features did not show any increase in the WBC count. CRP was also normal. So it would have misled us thinking of not a pneumonia, but maybe it was viral. That could be the reason. Anyway, he had features of shortness of breath, cough. Then they showed a X-ray with infiltrates. Then he asked what are the severity grading for pneumonia. So he expected the answers. This one, curb 65, and smart cope. All those. There was a discussion about pneumonia in this first. Same thing. It was same pattern by Dr. Deepak Gupta, I think. Then same according to that only they covered. Then what are the causes of pneumonia? We have to tell all that, viral, bacterial. Then he went into rescue menu. Same, sir, ARDS, rescue maneuvers. What are the rescue maneuvers? He asked rescue options like ECMO, all that, prone ventilation, everything we have to tell. Then patient went into ECMO. Then he asked the complication of ECMO. And how do you wean from VV ECMO? Weaning from VV ECMO and complications of ECMO. Then patient developed one condition on ECMO, that was hemolysis, basically hemolysis. So he asked the end of the vignette, what are the lab parameters you will send for hemolysis? Hemoglobin, bilirubin, LDH, all this he expected answer. It was like this. The case went like that.
Okay.
Then two short cases were there. Two short cases. One was inferior wall MI. The case started with patient developed some breathing difficulty, and a ECG was given which showed ST elevation in 2-3 AVF, and patient had shock also. So it was a cardiogenic shock, inferior wall MI with cardiogenic shock. And then she asked if the patients, when a posterior ECG was taken, which showed ST elevation in V7, V8, V9. So the answer was like posterior wall MI was there, and also patient had RVMI, right ventricular MI also. So these were the main complications. Then asked what will be the echo findings in this kind of MI. Echo findings, they expected that RARV dilatation, little more detail they wanted. They did not show the echo. They asked us what will be the findings. Then how will you, what are the management, how do you manage this case of cardiogenic shock? then it was a short case, so they wanted like mechanical circulatory support like IABP, as well as I have to tell at the end VA ECMO. In that way this ended. I can't remember properly.
Okay.
Then one
Okay.
case was like one young boy. He went with his family for a trip, some cycling he went. If he was found unconscious by the parents, taken to hospital. No, the ambulance came. They resuscitated him from there itself, and they put a LMA or something, and then they took to hospital. From hospital, they found the ECG. Nobody could tell what was the ECG because it was either a QT, long QT, or it could be a deep cerebral T waves, because we don't know if he fell and he developed a subarachnoid. Because next they asked, okay, what will be your initial investigation in this kind of unconscious patient? So they wanted toxicology screening, CT scan, CT brain, all this initial investigation. So when I said the CT scan, they showed the CT scan which showed SH. So we don't know if he had a SH and he fell, or he fell and he developed. Exactly, nobody could tell what
Yeah.
was it. So, or if that SH caused that deep cerebral T waves, also we don't know. Anyway, he was in cardiac arrest, so resuscitated. What are the causes for cardiac arrest? 5H, 5T, everything we have to tell. And then SH was shown, but CT angiogram was normal. There was no aneurysm. Patient was still intubated, unconscious. Neuros, he had increase in ICP. How will you manage the increased ICP? Patient had persistent, so we have to tell tier 1, tier 2, tier 3, tier 4, all we have to tell. So she said persistent increase in ICP is there. What will you do? So patient's echo also showed a less contractile heart. I don't know if he had some cardiomyopathy or something. But what she expected, the last vignette answer was, when I said barbiturate coma, we will do. So she said, what are the adverse effect of barbiturate coma in this patient? Maybe patient had hypotension. So if hypotension will worsen with barbiturate, or I don't know if cardiomyopathy will get worsened. Anyway, they expected all the tier management to be told and asked the adverse effect of barbiturate coma. So
Okay.
it went into ICP management.
Thank you.
Um,
So, regarding your CVS table, image में क्या था?
CBS images, they asked many questions. One was one patient, neurosurgical case. He underwent, the CT scan showed a craniotomy defect. He underwent a craniotomy. So the brain was bulging. Patient had loss of decrease in sensorium. So we got a CT done. That was the question. So it was a post.
Craniotomy में क्या था? Just I miss out. গৌরব পরে ফোন করছি, আমি একটা মিটিং আছি। हाँ, craniotomy में क्या था?
CT scan showed a post craniotomy. The bone was not there. So post craniotomy, and the brain was little bit bulging outward. I don't know if it is called subdural hygroma. It was not SDH, subdural hygroma something, because outside some fluid accumulation was there. So what is the reason for the decreased? Maybe we have to tell, we have to do a EEG to look for seizure. Anyway, CT scan was like this. They did not ask EEG or SDH. They asked a post craniotomy.
Okay.
Second was one abdominal CT scan of a lady. She had AF and she developed abdominal pain. So the CT scan was showing maybe mesenteric ischemia features because there was bowel wall thickening, and there was some gas in the liver. So portal venous gas, we don't know. Everybody, according to whoever I discussed, they said like that. Anyway, mesenteric ischemia I told because of this AF and all, and bowel wall thickening. Then third one was third one, typical one, saddle thrombus, CTPA, showing bilateral filling defect in the pulmonary vessels. It was a saddle thrombus, but the question was patient had glioma. So what will be your management? So basically glioma is there, so we can't thrombolize. Patient was in shock also. So clinically it was a hemodynamically unstable PE, high risk PE. So we have to tell anticoagulation. That was their expected answer. Then there was one more CT scan was there, sir. I can't remember those things. This was the main thing they asked in the CT scans.
X-ray?
Yeah, one more CT scan I remembered. One CT scan they showed it was a trauma case, and in that CT there was small pneumothorax, there was rib fracture, there was right endobronchial intubation, and there is subcutaneous emphysema. All these things were there. So we have to enumerate all these things. X-ray, they showed one X-ray which had a ICD. There is already a ICD. It is again a trauma case. ICD was there, but pneumothorax was also there. So they expect us to reposition the already existing ICD or put another one. So that was the X-ray. One more X-ray they put that I think I couldn't answer properly, but basically it was like some pneumothorax and all were there. I didn't know that one. This was the thing. One more abdominal CT was there. That I don't remember.
Okay.
So 2 abdominal CT, 2 X-rays. One was trauma and one ultrasound of lung ultrasound showing pleural effusion, which had some amount of septations. So they wanted to do like, what will you do next? What will you rule out? What is it effusion about? Pneumonia, like that. Lung ultrasound. This was the imaging section.
And what about the curve and loops?
Curves and loops. This time they asked. It was easy. One was they asked all 4 this thing that. Spirometry graph, no, sir, where obstructive pattern will be there.
Yes.
Yeah, one was obstructive pattern, one was restrictive pattern, one was I think fixed obstruction. Like same,
Okay.
this was all there in our this thing first.
Okay.
So that was one graph. Second graph, they asked about cardiac output, maybe little bit difficult. Cardiac output, they showed 3 graphs. It was like we have to come. A patient is actually a traumatic brain injury patient. He was intubated. Nurse called saying that there is an increase in the requirement of the vasopressors, and they showed this cardiac output graph, like this graph they showed, like this one. Like this. So it was like in decrease in the cardiac output according to. So we have to tell, we have to come down on the vasopressors, or a patient was given some barbiturate or something. So maybe we have to decrease that or something. That was one thing. Third question was about a ECMO graph. ECMO console was shown, and in that ECMO console, I believe that liter per minute flow was very high. 7 something it was going, 7 liter per minute. I told there was an alarm. Alarm was, I said either patient is hypovolemic. I don't know, sir, that my answer, I can't tell what was they expect. If P1 pressure, some pressures were also shown, P1, P2, P3. I think P1 pressure is high or flow was high, hypovolemic, something was there related to ECMO console. Then they asked TEG. In that TEG, they showed it was a ROTEM kind of thing, where there was FIPTEM graph was shown. FIPTEM was low, and the mean amplitude was also low. Basically, low fibrinogenemia, low platelet. What will you give? FFP plus fibrinogen. That was my answer. That was TEG. Okay, then 2 ventilator graphs they asked, which was easy. Ventilator 1 was easy. It was ineffective trigger. Missed efforts were there. What will you do? He wanted answer in appropriate sensitivity need to be adjusted. Next one was a graph that I don't know what was the answer. I think there was a improvement in the tidal volume. Two graphs they showed. One was tidal volume less, then suddenly tidal volume increased. It was a COPD patient. Maybe patient was given bronchodilators or PEEP was adjusted. That could be the answer. This was.
Okay.
Then this I think 1, 2, 3, 4, 6. Yeah, around 6. I told 6 curves. Yeah, there were 2 ECGs. One ECG was Brugada syndrome. Brugada syndrome patient actually came for fever, some infection. He had fever. ECG suddenly went into cardiac arrest or something, or decreased hypotension or something. I don't remember. Anyway, ECG showed Brugada pattern. So they wanted, what will you do next? Maybe we have to refer to a electrophysiology study. I don't know. Anyway, fever precipitated the Brugada syndrome in him. Fever was the cause. Another one was a VT, monomorphic VT. What will you do? Patient is unstable. This
Soft.
two ECG.
Okay.
2 ECG,
And
1 output monitoring. Labs, biochemistry, mainly everything was acid base only. One was our DK question. Patient, one elderly male, unconscious. Lab showed very severe acidosis, 6.9 pH, high anion gap metabolic acidosis. How will you treat? Fluids, insulin, and patient also had hyperkalemia. He wanted answer anti-hyperkalemic also. That was the answer. Second one was one sepsis patient. He recovered from sepsis. He's treated with linezolid. Lab was showing thrombocytopenia, some sepsis feature. So what will you do? So there is thrombocytopenia. It could be linezolid. So we have to tell stop linezolid, and that ABG acidosis also we have to tell. That was second one. Third is one meningitis. It was bacterial meningitis. Bacterial meningitis, they asked what is the treatment and all. CSF picture was shown. High neutrophilic predominant was there. Then that is what I can remember from biochemistry. Then there was one, I don't know where, maybe in images section or curves section, somewhere they gave a picture of that meningococcal septicemia, purpura fulminans. That picture was shown. So what is the causative agent of this? Streptococcus, I think I said. That was one picture. Then in the labs, yeah, I can't remember. This DK is there, like this, and sepsis I remember, and meningitis.
Yeah.
Like
That's good. That's good.
Yeah.
You remember a lot. So, Nasreen, we will meet again on the end of January, and before that, we will give you 2 invitation. One is for this event, and second is for the join as a faculty for mock examination.
Yeah.
Okay.
I felt like
Okay.
Farz Academies, mainly I went through all the recorded classes. It was very helpful, especially the nephro classes, Dr. Safe classes, and one Dr. Suvadeep Sen classes. All are very good classes because majority of my learning from that. And only thing Farz had, like, there was no live session this time. I attended one before. I think all the live session now made into recorded. I think if we hear all that recorded itself, it is very helpful. So I benefited a lot. Thank you so much.
Thank you. Thank you.
And I think the payment, like the fees for this is also very less, not very much. That is also very good. I felt.
Thank you. Thank you, Nasreen. Thank you.
Okay, sir.
Thank
Yeah.
you. Okay. Okay. Thank you.